Good afternoon and welcome to today's webinar, Engaging Communities of Color, Ensuring All Americans are Prepared for the Inevitable End of Life. This presentation is part of Compassionate Choices Staying Strong Together webinar series. My name is Tony Jemison. I am the National Constituency Manager for Compassionate Choices. I'll be serving in a dual role today as your moderator and as a panelist. Before we get started, please note that today's webinar is being recorded. Please also note that everyone is in view mode only. This means both your audio and video functions are disabled and neither will appear in the recording. We will have a formal question and answer session at the end of this presentation. If you want to ask a question of today's panelists, type your question into the question and answer box on your screen and click send. Also, please note to check send anonymously if you do not want your name attached to your question in the Q&A. We promise we will answer as many questions as we can during the designated time. Compassionate Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end-of-life journey. We envision a society that affirms life and accepts the inevitability of death, embraces expanded options for compassionate dying, and empowers everyone to choose end-of-life care that reflects their values, priorities, and beliefs. Today's webinar is an extension of who we are as an organization and our desire to reach all communities with specific messaging that speaks to the beliefs, values, and cultures of those communities. So with those housekeeping items out of the way, we're happy to begin. I'm happy to announce today's speakers. They are my colleagues at Compassionate Choices, Maria Otero and Dr. Rebecca Thoman. Maria Otero is the National Latino Constituency Manager and serves as a member of the Strategic Impact Committee and the Latino Leadership Council at Compassionate Choices. Maria has been working with minority populations for the past 27 years as a public health educator and administrator. Part of her job is to empower communities of color to have a voice in their own health and health care. Dr. Rebecca Thoman is the program manager for Doctors for Dignity here at Compassionate Choices. Dr. Thoman trained in family medicine at the University of Minnesota and has been involved in advocacy for more than 20 years, working on issues such as tobacco control, access to health care, cancer prevention, and gun violence prevention. Once again, I am Tony Jemison, and I am the National Constituency Manager. I have a Juris Doctorate from the University of Maryland School of Law, and I have, for over 20 years, been involved in diversity, equity, and inclusion, and have over 20 years of experience as an educator. Here at Compassionate Choices, we want a nation where everyone feels a sense of belonging, equity, and inclusivity, regardless of their age, race, ethnicity, party affiliation, socioeconomic status, religion, sexual orientation, gender, education, role within the organization, or geographic location. The constituency program is our department here at Compassionate Choices that's dedicated to outreach to diverse populations so that we can empower all Americans to make informed end-of-life healthcare decisions. Our program and today's discussion focuses on two particular diverse communities, the African American community and the Latino community. Our constituency program goals include three main bullets. One, to increase and diverse our supporter base to ensure our long-term objective, that Compassionate Choices will be increasingly turned to as an authority and leader on end-of-life choice. Number two, to increase organizational visibility in the African American, Latino, faith, disability, medical, and LGBTQ communities. And three, create and embody a more culturally sensitive brand through our content, creation, and community engagement. So at this time, I will now turn the next segment of the webinar over to Dr. Rebecca Thoman.
Thanks, Tony. So we can't begin our discussion about health disparities without acknowledging how the COVID-19 pandemic has had a disproportionate impact on the African American and Latino communities. This chart is a snapshot of the disparity where it shows, for example, in Louisiana, African Americans represent 33% of the population, but 70% of the deaths from COVID-19. The African American population is more adversely affected by the pandemic for a number of reasons. First, African Americans are far more likely to be employed as frontline workers, such as home health aides or grocery employees, where exposure to the virus is greater. In New York City, for example, 75% of the frontline workers are African American. And these same industries often provide no health insurance and little or no sick pay. African Americans have higher rates of hypertension, diabetes, obesity, and asthma, making them particularly susceptible to the severe effects of COVID-19. These coexisting health problems are not biological. They're due to social and environmental determinants of health, such as lacking health insurance, living in environments such as food deserts with unstable housing, exposure to environmental pollution. And these social determinants of health result from decades of public policies that have marginalized, segregated, and underserved the African American community. Similarly, Latinos are subjected to many of the same social factors. As you can see here, for example, in New Jersey, the Latino population is 19%, but the percentage of deaths from COVID-19 is 30%. The same social factors that result in more underlying health conditions, such as a lack of access to care, and they are also disproportionately represented in the front line and most at-risk occupations, such as meat processing, hospital housekeeping. Language barriers are at an additional hurdle, as well as fears of being targeted based on legal status. So end-of-life disparities are rooted in many of the same issues that have become glaringly obvious during this pandemic. For example, few African American or Latinos enroll in hospice care at the end of life. You can see here that 76% of Americans who use hospice are white, while Black, Native American, and Latinos make up a much smaller proportion. So why is this? Lack of knowledge about or access to hospice is a big one. Only about 1/3 of Latinos have even heard of hospice, and of those, only about 1/3 understand what it truly is. Unconscious bias among healthcare professionals, as well as the use of messages that don't resonate with non-white cultures, contribute. So for example, Medicare uses a literal translation of the word hospice as hospicio, but hospicio translates, depending on the Spanish-speaking country, as a place for orphans, a refuge for migrants, or a home for elderly people who have no family to support them. Clearly, this fails to capture the true nature of hospice care, which is comfort care at home that supports the family and provides spiritual care. There's even a marked difference in the kind of care that patients receive at the end of life. Black and Latino patients are undertreated for pain, and both groups are far more likely to receive invasive medical procedures, such as surgery, in the last month of life. Again, unconscious bias and perception of pain, language barriers contribute, but higher rates of invasive medical procedures may be due to a number of factors, and approximate cause of that is the relatively low rate at which African American and Latinos prepare for the end of life by creating advance directives. Nearly twice as many white as Black Americans over the age of 65 have a healthcare directive, and few Latino Medicare recipients have discussed their end of life wishes with their families. So health disparities are complex. They're rooted in systemic inequalities. And as we make an effort to improve end-of-life care in these communities, there are some factors that we keep in mind. And Tony and Maria is going to talk a little bit more about this in depth. But I wanted to touch on some. So cultural norms are poorly understood by mainstream medicine. That influences why Latino and African Americans may receive less hospice care. For example, a cultural norm about death. A fear of discussing death or an unwillingness to discuss death. Religious belief, sometimes that illness is God's will or that suffering is a test of faith. A very important factor is the family-centered as opposed to individual-centered decision-making. So advanced care planning messages that may be about personal autonomy and documenting what you want resonate with some cultures, but talking about planning as a gift to your family so that they can feel confident as they care for you is better received by others. Language barriers is another Maria will talk more about. And finally, I just want to touch on the historic mistrust in both African American and Latino communities. Their mistrust of the healthcare system. Overt discrimination has caused denial of care, being misunderstood or devalued by the healthcare system, and even blatant abuse from the not so distant past. That's why we emphasize building trust and using respected messengers as an important part of addressing end-of-life disparities. And before I hand the presentation back to Tony, I just wanted to mention medical aid in dying. I know that many of you joining this webinar advocate for medical aid in dying and know CNC primarily through that piece of our work. Just a reminder, medical aid in dying, modeled after the first Oregon's Death with Dignity Act, authorizes a terminally ill adult of sound mind to request and receive a medication that they may self-ingest for a peaceful death. Like a majority of Americans, Latinos and people of faith find medical aid in dying to be a moral choice. Catholics, the most common religion among US Hispanic families, support medical aid in dying at a rate of 70%. Although Latinos comprise 38% of California's population, according to the most recent report from the California End-of-Life Option Act, only 4% of people who use medical aid in dying were Latino. So we have to ask, are there unique barriers to access in this community? Similarly, majorities of African Americans also support medical aid in dying, although at slightly lower rates. National and state-based surveys indicate majority support. I also wanted to mention that it's really important to know that you will hear arguments from opponents of medical aid in dying that suggest medical aid in dying will be used against African Americans or put those communities at risk of abuse. There's absolutely no evidence. And these implications are very negative in and of themselves because they prey on fears and they undermine the overall trust in the healthcare system, which further undermines efforts to overcome disparities. In California, African Americans make up 7% of the population, but according to the most recent report, less than 1% of medical aid in dying users were African American. So with this backdrop, I would like to hand the discussion back to Tony.
Thank you, Dr. Thoman. So now I'm going to talk a little bit about how we engage diverse communities. At Compassionate Choices, when we approach diverse communities, we use some best practices for authentic engagement. We start by establishing trust, and we establish that trust by showing up. Before COVID-19, we were out in the community supporting events so we could determine what matters most to those we were meeting with. So after we establish that trust by showing up, next, we meet people where they are, meaning establishing the right way to start the conversation. This is extremely important. In the African American community and Latino communities, we start with end-of-life education, not medical aid in dying. We start with advanced directives and end-of-life discussions because as we learn from Dr. Thoman, they are often not prepared to have end-of-life conversations. Next, we are open to listening because we recognize that in order to address the needs of the communities that we're serving, we must also recognize that we do not have all the answers. Next, we ask thoughtful questions and always are sincere and authentic so that these communities know how committed we truly are and want to change the way these communities experience death. One of the ways we have been working in the African American community is through establishing our African American Leadership Council. This is a group of 13 leaders from around the country who come from diverse backgrounds. We have a physician, we have pastors and nurses, community leaders, financial planners, and others who help us strategize and participate in our outreach efforts. They have written op-eds and even met with members of Congress on Capitol Hill. Messaging for African American audiences. Dr. Thoman touched on this briefly. I'm going to go into just a little bit more detail. So although polling has shown us that all demographics support medical aid in dying, we have found that there is a gap in end-of-life education in the African American community. So we begin the conversation with the basics around end-of-life. Normally, when we talk about these issues, end-of-life issues, we talk about them through the lens of the personal autonomy message. In other words, we focus on the individual. But in the African American community, oftentimes there is more value placed on involving faith, family, and community in decision-making. The African American community is generally more comfortable making decisions that are based on input from those within their inner circle. As Dr. Thoman talked about also, there is a lack of trust in the African American community as it relates to medical and healthcare systems. And this is a real barrier. Things like the Tuskegee experiments here in Baltimore, Johns Hopkins University, and then the differences in how the medical community treats African Americans has added to that fear. So that's something we keep in mind when we're discussing end of life and discussing just healthcare issues in general. Finally, language is important, and getting the language right when speaking to African Americans is extremely important. So for example, language such as reclaim may not resonate, as some African Americans feel as though they never had a real say in their healthcare or healthcare decisions. So here at Compassionate Choices, we prefer to use the term claim instead, because we are encouraging African Americans to take the lead in planning their own care. At this point now, I will pass it along to Maria Otero to discuss our Latino outreach efforts.
Thank you, Tony. The Latino Leadership Council was created and convened in 2017 to improve end-of-life care outreach in communities of color. It consists of 17 members that go from chief executive officers, physicians, civil rights activists like the legendary Dolores Huerta, to Hollywood actor Mauricio Ockman. These multicultural community leaders, executives, and physicians have served as the partners in educating and informing communities of color about end-of-life care and choice. Their voices have helped ensure that communities of color have access to the full range of end-of-life care options in the United States. Next slide. As previously stated by Dr. Thoman, there are several factors, norms, and values that influence our Hispanic Latino population end-of-life care. First of all, I would like to share with all of you that the Hispanic Latino population is a diverse group. From a cultural and social perspective, we represent a wide variety of national origins and ethnic and cultural groups. We share certain attitudes, values, customs, tradition, and even the same language. The terms Hispanic and Latino are often used interchangeably. However, they actually mean two different things. Hispanics refer to people who speak Spanish and/or are descended from Spanish-speaking populations, while Latino refers to people who are from or descended from people from Latin America. We know the Hispanic Latino population is the largest minority group in the US, and it is expected to continue to grow. So in order to provide culturally consistent care, perspectives of health, illness, and death must be viewed through the Hispanic Latino culture lens. There are several cultural values that affect the end-of-life care. These include the importance of family involvement, the influence of religion, and the value of relationships. For example, in many families, the oldest male or female usually holds the greatest influence. Therefore, he or she might be the key factor in health decisions for others in the family. Also, another example is that oftentimes the family may prefer to hear about any medical news before the patient is informed so that they can shield or protect their loved one. We often deliver news like this very gradually. As I mentioned before, there are a diversity among cultures. There's also diversity in religions. We consider ourselves religious, but regardless of religious association, we have a strong faith in God. The basis of any end-of-life decision is grounded in the church's teachings. The emphasis is on prolonging life rather than preparing for death. So be advised that there is differences at the end-of-life prayer and rituals. On regards to relationships, trust and respect is very important. Oftentimes, providers, nurses, or health educators need to gain the trust and show respect to the patient and her family. Another cultural value that goes along with trust is respect for hierarchy. We respect our doctors, our nurses, our health educator, anybody that is on the health, as a healthcare professional. We often do not disagree or challenge anything they have to say. Although death is not considered a taboo, within the Hispanic Latino community, there is a reluctance to talk about it. So an important factor when it comes to education about end-of-life planning is providing community education and providing educational materials in the language our population they prefer. Next slide. So how do we communicate with our Latino patients and their relatives? Compassion and Choices has an array of Spanish language materials and continues to adapt materials to reach our diverse Spanish-speaking community. Like I mentioned before, it is important that our community members have access to these materials in the language they prefer. The literature recommends several processes for developing educational materials and messages for our Spanish-speaking Latino audience. And I will touch very briefly on some of them first. Like number one, for example, first, going beyond the translation process. The educational materials need to be written in the population's native language. In this case, we're talking about Spanish. For example, like Dr. Thoman stated earlier, some important concepts like hospice or living wills or advanced directives do not resonate or do not exist in the Spanish-speaking world. So it is very important that when we are unable to write messages in Spanish, a good interpretation is facilitated in order not to lose the concept of the message. The Latino Leadership Council has been involved in identifying messages, materials, and are needed to empower our Latino community around end-of-life decision making. Another concept is involving the community. We know that a wider audience can be reached and will be reached with a cultural message that includes individuals with a variety of acculturation levels, literacy abilities, and all stages of material development. Selecting what is the best format to deliver this message. Are we considering a booklet or brochure, posters? And we will know more what is the best method when we involve the community, like I mentioned. And finally, incorporate the concept of familismo personalismo, confianza, y respeto, which are the concepts of family networks, personal relationships, trust, and most important, respect. And now I will pass the conversation back to Tony.
All right. Finding inroads. So it's important, all the work that we're doing at Compassionate Choices, African-American outreach, Latino outreach, working within the different entities within Compassionate Choices, but it's always important to have outside entities that can get our message across. So yes, we are partners with entities at national levels that help us to get out our resources and our message in the community. So some of the national partners that we have are the NAACP, the National Urban League, National Black Nurses, the National Baptist Convention, American Public Health Association, the National Hispanic Council on Aging, the Latino Commission on AIDS, Health Hispanic Network, Latinos for Healthcare Equity. We've also identified that community health worker trainings in the Latino community and churches in the African American community are gateways to making these inroads. And we hope to continue to grow these programs and find other ways to engage. Next, I'm going to talk about resources, but before I do, I would like to give a special thanks to our panelists, Maria Otero and Dr. Rebecca Thoman. I also would like to give a special thanks to Wendy Miner, who is going to be working the question and answer box, and we need her, and she's a great member of our team. Brandy Alexander, who's the National Director for Constituency, and who helped guide us as we practice this presentation. And finally, Kim Tashini, who is, she's overseeing all of this, and she's making sure that we're technically sound and strong. And so I want to give a great thanks to these individuals that helped us to put on this presentation for you all today. Before we start the question and answer period, again, I want to share a few updates from Compassionate Choices, and this is in relation to our resources. So one of our resources is our end-of-life care planning. And so in our end-of-life care planning resource, we have a Plan Your Care Resource Center, which gives you tools and guides. We have tools to finish strong, as I talked about. This seminar, this webinar is about staying strong. And then consultation services, and you can call 1-800-247-7421, or if you choose, email eolc@compassionatechoices.org and get as much information as you need about end-of-life care planning. Next is our COVID-19 toolkit. Compassionate Choices likes to stay on top of things, and so we immediately developed the COVID-19 toolkit as we saw this pandemic growing and growing. Under the toolkit, we have such things as understanding your options, using telehealth to reduce your risk, the impact on underserved communities, advanced care planning, a COVID-19 addendum to your advanced healthcare directive, and dying in the age of the pandemic. To find these resources and to read more about these resources, please visit www.compassionatechoices.org/end-of-life planning. So at this time, we're going to go to our question and answer period, and I will be asking the questions and then directing those questions that are not related to me to anyone else who has, to Maria or Dr. Rebecca Thoman. Okay, so this question is for Dr. Rebecca Thoman. The questioner wants to know, in compiling medical data, what do you think is the most important thing that needs to be done when you're compiling data in regards to disparities and discrepancies in communities of color?
Okay, I'm not sure would you read it again, Tony? I want to be sure that I answer the question as it's intended. Read that question again.
Right, so what I'll do is, it is kind of a little convoluted. So I will, basically the question is, when data is compiled, to make a determination as to how to garner the numbers in terms of disparities in African American and Latino communities, how is that data generally compiled? Because many people in these communities believe that the data is skewed. So if you can, could you answer how the data could possibly be compiled?
Well, most of the data that I'm talking about, and I'm not going to talk about the COVID-19 because I know that the health departments are collecting that data and have limited data on racial categories in some instances. But for some of the data that I talked about, which is comparing, for example, rates of advanced care planning, this has actually been done in settings where going into communities where there are Spanish-speaking elders and surveying them on what they know about hospice and finding very low rates of knowledge, or going to African American communities or health centers where there are large proportions, and then surveying people and comparing between African American and white. Also just looking at Medicare, sometimes Medicare data will have racial differences in terms of who is filing for hospice support or coverage in a care setting. I'm trying to think what some of the other surveys, most of these have been done in the field, in the practice, reaching out to patients in clinical settings and doing either some surveys or, for example, hospice, quality of hospice, surveying Latino families to ask if their needs were met in their hospice experience, as opposed to white families, finding some gaps there where Latino families are feeling that their spiritual needs are not met, or that kind of thing. So these are usually done in the field in clinical practices.
Thank you. Okay, next question we have on the floor is, are younger people from communities of color more willing to trust healthcare providers? And I will answer that question. I think that varies. It varies on the amount of information or what's been passed down to young people by their relatives, by people in their community. So I think that there's not a stock monolithic answer to that question. I think it again depends on one's experiences with the healthcare system, what one has seen elders experience in the healthcare system. So I think the answer to that is probably yes and no, depending again on one's experiences. Okay. Okay, so we're going to move on to the next slide. All right, upcoming webinars. So the next webinar that we have in our Staying Strong series is opportunities to expand telehealth use amid the COVID-19 pandemic. And that's going to take place on Tuesday, June the 2nd. On Tuesday, June the 9th, there'll be a town hall webinar, and that is entitled, How the COVID-19 Pandemic is Changing End-of-Life Care, the clinician perspective on the good, the bad, and the way forward. On Tuesday, June the 16th, Becoming a Powerful Virtual Advocate, How Can Your Online Presence Inspire Action? And on Thursday, June 25th, Ask Me Anything, a conversation with the Compassionate Choices End-of-Life Consultants. To learn more about these webinars and to register, please go to www.compassionatechoices.org/webinar series. Staying on the theme of webinars, next slide, we have an archive of previous webinars. So if you want to look at what we've done in the Staying Strong series prior to today, we have a number of webinars that you can view. Again, going to www.compassionatechoices.org/webinar series. And these past sessions have included National Healthcare Decisions Day Town Hall, Navigating End-of-Life Care and Choice During the Pandemic, How to Become a Powerful Virtual Advocate, National Healthcare Decisions Day, End-of-Life Decisions, Guide, and Toolkit, Diane Rehm, formerly of the Diane Rehm Show, on charting your personal journey from life to death. And this is hosted by one of our partners, the Raven Group. Living and Dying with Dementia, Taking Charge of Your Personal Values, hosted by the American Society on Aging. A conversation on grief and loss. What does it mean to finish strong? Featuring Barbara Coombs-Lee. And finally, medical aid in dying across the states, a compassionate end-of-life care option, part 1 of 2. Again, you can view these previous webinars on www.compassionatechoices.org/webinar series. You can also follow us on social media at Twitter at Compassionate Choices and Twitter at Kim Callanan, Facebook at Compassionate Choices, YouTube, Compassionate Choices, and Instagram, Compassion and Choices. Finally, Compassionate Choices is funded almost exclusively by individual donors like you who are committed to issues of end-of-life care and choice. Please consider making a donation today to help us expand our work and ensure that everyone's priorities and values are met at the end of life. Every donation, any amount, makes a difference, as these donations allow us to continue improving care and expanding options at the end of life. And thanks to a generous supporter, all gifts will be matched 1-to-1 through June 30th, 2020. So it's a win-win all the way around. If you enjoyed the presentation today, and we hope you did, please consider making a donation so that we can bring similar presentations to other people. You can go to our website at compassionatechoices.org/donate and donate online. We thank you for supporting today's webinar. We hope that you will continue to support us by attending future webinars and watching past webinars. And we hope you continue to support us by making a donation. Again, that donation will be matched 1-to-1 through June 20th, through June 30th, 2020. And donations will help us continue the work that we're doing in the community, work that we know you support just by your participation in today's webinar. So we thank you for attending today, and everyone have a wonderful day, and please be safe.